We begin today with a new proposed policy on migration aimed at preventing the exodus of Nigerian medical workers abroad. In the week, President Bola Tinubu took a step in this regard when he approved the National Policy on Health Workforce Migration. Speaking to this on his verified X handle, the Minister of Health and Social Welfare, Professor Muhammad Pate, said the policy is more than just a response to the exit of healthcare workers. It's a landmark and comprehensive strategy to manage, harness, and reverse health worker migration, he explained. At the moment, Nigerian healthcare workers are leaving the country in droves for greener pastures. The consequences is a reduction in manpower, leading to additional workload and extended call hours for those that stay behind. The decision to leave is blamed on a number of factors, including poor working conditions, poor remuneration, inadequate facilities, and insecurity. The minister has explained that the new policy sets a framework for the regular review of working conditions. It will ensure that health workers, especially those in the rural areas, receive the recognition and reward they deserve. Well, for more on this, we have joining us in the studio the Minister of Health and Social Welfare, Professor Mohammed Pate. Great to have you here, Minister.
Thank you. Thank you for having me.
Well, let's go straight to the new policy that you announced on your social media platform. Can you share with us briefly the key components so that Nigerians can understand what we are dealing with here?
There's a context within which Nigerians will need to understand that policy pronouncement that was made last week. And that context is that the health sector is undergoing transformation under the leadership of the President. There are pieces of the transformation that have to do with expanding primary healthcare infrastructure equipment, expanding the teaching hospitals and the higher level services that need to be provided, but also the lifeline of the health sector is the human resources, within which the federal government had doubled the quotas for training of health workers domestically and is retraining 120,000 frontline health workers, of which 10,000 have already been retrained in the front lines. This policy is a policy to address the issue of migration. We call it a managed migration. It is not a policy to stop anybody from going out. It's a policy that takes into consideration the reality that there is a demand for medical workers all over the world, the wealthier nations. And people are free to leave, but also others will come back. And for those who come back, how do we make it easier for them? And it puts forth 5 planks that in a strategic way, a thoughtful way, how do we manage this reality of migration of health workers abroad, taking into cognizance that people are free to leave, it's their right, but government cannot wait and just hold on to the few that are staying with the excess workload that comes with it. So the first one is on incentives. It's incentives to enable the distribution of the health workforce to the rural areas, to recognize those who have stayed and served in the rural areas, to also provide a path for them, to provide the enabling environment, the massive infrastructural investment that the federal government is doing. For instance, yesterday the President flagged of 10 major infrastructural investment. The groundbreaking took place in 10 sites across the country for diagnostic centers, oncology. 6 cancer infrastructural upgrades are already on the way between Ministry of Health and the NSIA. And so many other elements that will improve the working environment. And for those in the front end, to have housing, to have other means for them to be able to afford mortgages, other credit lines, and to really improve, provide them the incentives and recognition so that health workers broadly, doctors, nurses, pharmacists, enjoy. That's one, including their mental health well-being, their periodic checks, and to ensure that they are secure because we have this security. This is to do with the incentive. The second plank of this policy is to do with the capacity building, their training, the quality training, the continuous professional education, the postgraduate education, training opportunities abroad for them, using technology, digital technology, telehealth, and how they can use that to improve their capacity to deliver services so they feel connected in this global world. The third plank is what we call health diplomacy and ethical recruitment. For the recipient countries who recruit workers that were trained in Nigeria, given that public investments went into those training, can they also reciprocate by helping us expand pre-service training so that we train more doctors? And there's experience in many countries like Philippines, like India, and a few other countries, that when you do that, when you train more, if you train 10 health workers, 3 may leave, but 7 will remain. So we're replacing those who were leaving. And also to explore whether we could have agreements, almost a corridor that folks can go and they can rotate back in. That's the realm of health diplomacy and ethical recruitment practices.
Right.
So they are also treated respectfully in the recipient countries, because some of these countries don't have the health workers we have, and we have well-trained health workers, which we are proud of. The fourth element, if I will say, is using data to track, having a registry to know the patterns, the trends, research, applying best knowledge, understanding the issues, and adapting the policy over time. And the final piece is the governance of it, knowing that federal government is not only the employer of health workforce. States do, private sector does, international organizations do. So how do we have a governance mechanism through the Council on Health, which has federal government, state governments, through what the Federal Ministry of Health itself does, and to have a national health human resource program with a coordinator that will ensure that this policy is not just put on the shelf, but that it translates into improvement over time.
I was going to come to that. We have so many policies in Nigeria. We announce them. They are on paper, look shiny, look fantastic. And what you said is very comprehensive. It looks like there was thought put into it. You took your time, you and your team, to do all of this. But the question will be, you did say that you're not stopping people from pursuing their dreams abroad if they wanted to. But all that you've put together, how long will it take to see the impact? Because this has been happening, the brain drain, for quite a long time. So you have this plan in place. How soon do you hope to see the impact of this plan?
So I think by now Nigerians know that President Tinubu's government is an action government. It's not about just the policies, but actually putting it into practice. As this policy was developed and consulted upon with different stakeholders, elements of it were already being executed. When I mentioned the retraining of frontline health workers, already 10,000 frontline health workers have been retrained in the last 10 months by this administration and more.
In what specific areas?
These are frontline health workers, right. Community health workers, nurses, midwives,
right.
in terms of the service that they will be able to provide to Nigerians. And there are other elements that have to do with the expansion of the infrastructure, the quality of the infrastructure. I mentioned to you the 10 diagnostic centers and oncology centers that the groundbreaking has taken place through
right.
MedServ, NSIA, and the 6 that the federal government has put in this budget and has contracted with NSIA to be able to execute them. When Nigerians will see those in 12 to 18 months, they will be open. There are many infrastructural projects that are underway, including expanding classrooms, hostels, wards, so that the environment within which health workers operate will also be better.
10,000 seems very small, though.
Well, if you listen carefully, yes. 10,000 on a path to 120,000 by 2027.
Right.
There are 350,000 health workers in Nigeria of different types. So, but for the first time in more than 10 years, this massive undertaking to retrain existing frontline health workers is being undertaken. That is a concrete action. It's not just being planned. The resources identified, the curricula revised, the trainers trained, and the retraining is already underway. So when you ask about execution, this is a government that is taking actions to address these long-standing issues that we have in our health sector. So right. I believe that over time, and I will tell you, we have seen health workers that are here in Nigeria, many of whom have no intention of traveling abroad. They are enjoying the work that they are doing and serving sometimes under difficult circumstances, but they want to build this country. This is our home, and they are not choosing to go abroad. And the majority of Nigerian health workers are in that category.
Yes.
The few that want to go, it's their right, and government cannot put a barrier to them. We hope when they go, they will also come back over time with better skills. Okay. We hope even those that are abroad will consider coming back. And guess what? There are Nigerian health workers, there are senior doctors, professionals in the United States, in the United Kingdom. They are already on their way back and already coming back to see how they can contribute.
Right.
Because at the end of the day, when Nigerians are saying, okay, let's go outside the country, wherever you go, you are a Nigerian. And there's no one who will fix this country except if Nigerians come and put hands together and fix it. That is the spirit of what Mr. President is trying to get us to do in the health sector.
Professor, you are aware that quite a substantial number of public office holders, those in authorities, they engage in medical tourism because of the poor infrastructure of medicine in this country, and so they can afford it. Majority of Nigerians cannot afford it. So with what you're telling us, you're working towards a situation where we have good medical facilities in Nigeria with doctors and nurses so that people can, or the brain drain of medical tourism can be reversed. When are we going to achieve this? So, and it has to start with example, doesn't it?
Well, you put up an opinion which is, I think it's reasonable to put forth that opinion. But the idea of tourism across sectors occurs for different reasons. Whether it's education tourism, developmental tourism, religious tourism, or health tourism. It's a global phenomenon. People from the United States go to Asia for medical care. People from the United Kingdom go to South Africa for medical care. And I tell you, with what this government is doing over time, you will see others in Africa coming to Nigeria. And already it's happening from our neighbors in Western Central. They're coming to Nigeria for medical care. And other countries will have their citizens, and we hope one day, even from the UK and others, they will trust the quality of care that we have. That is our vision. That's why we're investing massively in the infrastructure, maintaining the high quality trained health workforce that we have. Have you asked yourself, why would somebody who is trained in Nigeria be hired overnight and work in the United Kingdom? Because the training is good. Now, if we have the infrastructure and they're here, you can see in the future, it is possible that folks might leave European countries where they have months of waiting period. If you go to some countries, there's waiting periods for medical care. They can come here and get the care and pay for it. And sometimes the private sector will play. And the amazing private infrastructure that is providing services of high quality, sometimes by Nigerians in the diaspora who have come back to set them up. So it is possible if we believe that we want to make this different. But if we fold our hands and say, oh, it's inevitable, things are run down, infrastructure is poor, we're just creating excuses. Believe you me, when the environment changes, we will see many people stay. But there will be those who may go because of privacy, because they also want to do some shopping or they want to do some other. There are many reasons why people travel. Maybe they have a relationship with their physicians for many years. They won't change it overnight. So long as public financing is limited in its role. An individual, if you want to do anything, you can go and do it. It's your right. Government should not tell you what to do by yourself. But the role of public financing is something that we're trying to change so that we invest that in the infrastructure, in the service delivery, in the quality of the professionals that we have so that they can provide services
How
here.
closely do you work with medical associations? Because sometimes government sets up policies on what they think are the problems of the people, whereas the people for whom those policies are meant want something different. So how closely do you work with these associations?
Very closely. So overall, when this administration started, we had a People's Voices survey, which asked 2,500 Nigerians through phone interviews, what's their expectations? What is their experience? And based on that, articulated an agenda, the 4-point agenda, which is the President's Blueprint for Health, and which we have been implementing with very tangible results. Now, the Medical Association, from day one, we've engaged with all medical professional associations, whether it's the NMA, whether it's the Consultants Association, whether it's the resident doctors periodically, whether it's Nurses and Midwifery Association, whether it's the Laboratory Science Association, to have an inclusive approach. And there are long-standing issues, I have to admit, over decades that have been between them and previous teams. And we are taking responsibility for those and making progress in trying to address them. In shaping this policy, at least 200 to 300 different individuals were consulted. They made input, civil society, development organizations, World Health Organization, state governments, even within federal government, Ministry of Labor, Ministry of Education, including the Attorney General and Ministry of Justice, so that it's an inclusive. You don't develop policy just like that. There's a thoughtful process, analysis to understand what is the experience, what is the experience globally of what has worked and what hasn't, and how do we put in some thoughts on how we can resolve our problem, and how do we review that, so that over time, now 6 to 12 months, 12 to 24 months, we can see the impact of this policy. And it's reasonable to say, let's take stock of it. That's why we anchored it around the governance, around the program, around the Council on Health, so that we can begin to address. It's better than just holding back and just complain.
Right. Prof, I have to ask you about herbal medicine. I know that's not your forte, but you're the Minister of Health. Yes. There's so many countries such as China who really have developed their herbal medicine system. We have a lot of resources, you know, in our bushes, well, not bushes, but you understand what I'm saying, in our forests to develop that. We've had it for centuries, but it looks like we're no longer, it's an area that there's no focus. Are you doing anything in that regard?
So, wonderful question. We are very richly endowed with biodiversity in our country, of all kinds, including plants. And in the field of medicine, phytomedicines, plant-based medicines, they have a potential. They have to be studied, understood, that they are safe, they are efficacious. There's a scientific method to go through that. We have an institute, National Institute for Pharmaceutical Research, NIPRID, which is here in Abuja, Gudu, which has been doing research on different phytomedical plants. Some have already been developed and commercialized for sickle cell disease, for instance. They're working on things for diabetes, for hypertension. But those have to be properly studied and regulated, including by NAFDAC. Because
we are still studying by this time, at this stage of our country.
Well, you never reach the point where you say you know everything.
Right.
So you have to keep an open mind, and you have to use scientific method. Otherwise, you'll turn yourselves into a country dominated by quacks.
But we want to see that those on shelves too.
So that is what I'm telling you. If you go to NIPRID, they will share with you the products that are already in advanced stage of development, and some are being commercialized, like Naprisan for sickle cell disease, which had been developed here. So that's something to celebrate. But there are many more that will come. But the point that I'm trying to make is that plant-based medicines, if they are not properly classified, you can have liver disease, and you take a plant-based medicine that has been inadequately studied. It can tip you into liver failure because the plant medicine, what is the chemical in there, may be toxic to your liver. If, for instance, you have kidney disease, and you take a plant-based medicine that has not been studied for its safety, and its side effect includes damage to kidney, you can take it above the dose. So how do you determine the dose of what is right for you? 1 cup, 2 cups? And what if you take excess? Almost everything taken in excess can be harmful. So how do you advise your patients? So the richness that we have in our indigenous knowledge, in our biodiversity, needs to be harnessed. And that has to be studied, and in a way that allows us to give guidelines that is safe, is effective. So we're on that path. When the president initiated the healthcare value chain, we're looking at various streams of value chain, including the phytomedical value chain, and NIPRID is working on that. We're just 1 year in office, but we're taking those steps in a serious, in a deliberative manner. Just like you mentioned, China, India, many other parts of the world, yes, we cannot discount what we have.
Yes.
But we have to also be thoughtful and use the scientific method to understand the safety and the applications, the experience, and even when we use them, how many people have suffered from liver failure from taking herbal medicines that were unregulated? So those are some of the issues, and there are other aspects, other elements in government that are dealing with this as well, not only in the health sector. Okay,
we're almost out of time, but finally, we have a rich diaspora in all sectors, whether it's medicine, nurses, everything. Have you developed a structured approach for them to bring back their knowledge into Nigeria? I mean, people come in personally on private visits and all of that, and missions. Is that something that is being done by your ministry in that regard?
I spent 30 years, most of my last 30 years in the diaspora.
Yes,
myself.
I was going to say you are one of them that ran away.
Well, I'm here and I've been here and I've contributed and I'm contributing.
Yes.
And my colleague, the Minister of State, was also really a successful medical practitioner in the diaspora who is also back. And there's several Nigerians in the diaspora in health, in other sectors that are coming back to contribute to this country. Now, in government and this administration, this president is very deliberate about engaging the diaspora. And NIDCOM, the Nigeria Diaspora Commission, is being led by an exceptionally talented lady, Honorable Dr. Abike Dabiri, who has mobilized diaspora across sectors, not only health, education, sciences, entertainment, business, and all of that, and harnessing the potential of our diaspora. The Nigerian diaspora is one of the most successful diasporas anywhere in the world, and the president appreciates it. And we in health have been engaging with them. There's Association of Nigerians and Nigerian Physicians in the Americas, other diaspora groups. There are MANSAG in the UK. So across different professional groups. And we have a constant engagement. The question we ask ourselves, how do we harness them? How do we make it easier for them? You'll see in this policy, to make it easier, the re-entry. If you are licensed somewhere, how do we make it easier that you are licensing? You cannot be licensed, let's say, in one category, and then when you come home and get a different category, then you cause damage.
Yes.
So you have to understand those regulatory side as well, but streamline them. How do you make it easier? What support will they need? And I think those are things that are, let's say, required, and I think the government is working to attract the diaspora. We encourage them. We say to everyone that goes, when you go, try to come back.
Right.
For those that are there, also come back so that we join hands to build this country, because the president is very focused on making Nigeria a prosperous nation that is people-oriented, and health and the well-being of the Nigerian people at the center of it. And that's what we're working towards in line with this vision.
And following from this conversation with the minister, we'll have other guests in the studio. Stay with us. We'll be back shortly. Well, welcome back. We still have the Minister of Health, Professor Partey, with us for a few more minutes. Minister, welcome once again. You're still here with us. Can you speak to the Mpox outbreak in Nigeria? We have 39 confirmed cases. How are you handling the crisis?
Yes. This past week, the World Health Organization declared Mpox a public health emergency of international concern, because of the cases that were found initially in the Democratic Republic of Congo. More than 14,000 cases, and have spread to at least 14 African countries. In Nigeria, as you know, we have had Mpox, a clade of Mpox for the last 4 years occasionally pops up. In this year alone, we have almost 700 suspected cases. Only 39 were confirmed, mostly in Bayelsa. Even anticipation or knowing what was happening in the continent, since almost 2 weeks ago, we intensified our surveillance to be able to identify those cases and be able to trace their contacts and ensure that they are not allowed to spread. And we put measures at our airports in collaboration with the Ministry of Aviation so that there are health declaration forms that everyone coming into Nigeria, so that the disease doesn't spread, particularly the clade from DRC, which is the more virulent clade than what we had, so that we track where people are coming from, and so far we have not detected those that have been imported. But we are working with Port Health Services in the ministry, the Nigeria Center for Disease Control, and the aviation authorities to ensure that we keep our border, we fortify our surveillance at the port of entry and in the country, so that we can be able to deal with it if cases increase. But so far, I think we are not as affected as many of the other countries, especially DRC, which is the epidemic, which is the epicenter. We have also been able to identify some thousands of doses of vaccines, which will be arriving in Nigeria next week for Mpox. But there is a global shortage of the Mpox vaccine. But given the shortage, if we identify new cases, the strategy will be adapted so that we vaccinate to ensure that it doesn't spread. So all in all, to assure Nigerians, the Nigerian public health system is competent, has been working even before the public health emergency of international concern was announced, and will continue to do that, and to let people notify health work facilities when there are symptoms or suspected cases, and for people to avoid ways to spread them in terms of contact with people who may have the disease, avoiding so animals. I mean, that's bushmeat is one of the ways, particularly those in the bushes. I think those are the ways that people should be more careful. And personal hygiene is always useful. Safe sex measures, I think, will be also very helpful, because the clade that is from from DRC is spreading in younger age groups than the clade that we have. We had clade 2, which is the one that Nigeria had for a few years. But the DRC clade that led to the declaration of this public health emergency is clade 1. It tends to affect younger people. Right. So being mindful and practicing good hygiene and avoiding contact with infected material, infected people, and notifying health facilities is the way to go, while government is doing its part. Right. So the health system and the public health system, through NCDC, through Port Health Services, is competently dealing with this emergency. Okay.
So we also have the other problem, cholera outbreak. So what are the state of things now? So
what Nigerians don't hear a lot about the ongoing outbreaks. Last year it was diphtheria outbreak in 14 states. We stopped it. There was a task force. When cholera emerged this year, the president set up a cabinet level committee working with the NCDC. And for the last 5 weeks, the number of cholera cases have been going down. And we mobilized vaccines against cholera, but we're not declaring victory because it's still the rainy season. Again, it's sanitation, it's hygiene, avoiding contamination, stopping open defecation. These are things that have to do with the behavior of people. The more hygienic people, the better the hygienic practices, the less this infectious disease will spread. And Nigerians so far have been responding to the messages and the support that we have from the states. And that's why we're seeing the cholera numbers actually going down steadily. But we're not relenting, right, because it can also go the other direction. Yes. Infectious diseases are with us, and we just have to be vigilant. And that's why the health security pillar of the president's agenda is an important one. And what the NCDC and Port Health and the surveillance system, that's what it's doing, is fortifying our defenses from these infectious diseases. So finally, at what stage, from what you say, it looks like everything is under control, but at what stage is an emergency declared? Well, in Nigeria, not by the World Health Organization, in Nigeria, concerning these cases? There's already a public health emergency of international concern. I'm talking about Nigeria now. So the whole world is now dealing with this as a crisis issue. And the implication of that is, for instance, there are not enough vaccines. The whole world, the capacity to produce vaccines, no more than 2 million doses of vaccines. So this emergency is to enable raising the resources to pay for these expensive vaccines, the emergency authorization to make the vaccines available. The emergency allows these measures to be taken place, but it's not something that it's country by country by country. When you look at the cases that we have 39 confirmed cases. That's nowhere near the 14,000 cases that the Democratic Republic of Congo has. But that doesn't mean we should just wait until we declare emergency. We hope that the cases in Nigeria still are kept at a very low level. That is the idea of health security and fortifying our defenses, which is through good surveillance system, and when cases are found to be identified, their contacts traced, and for them to be supported through this element, and when we have vaccines as a public health measure to provide that. So those are the measures. It's a really important function that the public health system does, and most people will not see that. You only see the cases that come through. But the success that we achieve in most instances in outbreaks, in the diseases that we don't allow to escalate, right, and how we contain them. Okay. Professor Partey, thanks once again for joining us. Thank you very much. Thank you.